I unmuted myself. I believe we're good.
Mhm.
Good morning, everyone. Thank you for joining us for rounds today. I am Gillian Shaw, one of the pathologists in Coplow, and I will go ahead and get started. Maybe I can get the slide and go forward. There we go. Okay, so the first case that I have to present is hold that thought, 10-year-old domestic short-haired cat. Oh, domestic long-haired cat. Not that it matters. The history we got was fairly brief, and they say the left eye has chronic anterior uveitis and secondary glaucoma of approximately 4 months duration, non-responsive to topical medical therapy. Recently developed hyphema. Patient also found to have toxoplasmosis and was treated with oral clindamycin. That does imply that they did some infectious disease testing to come to that conclusion. The other eye, they also say has anterior uveitis, which is kind of interesting. But anyway, so here is the globe. Cornea is always at the top, optic nerve is always at the bottom. What we do have is distortion of the anterior segment of the eye, specifically the anterior uvea. So this right here, this dark line is where the base of the iris should be. And you can see that the base of the iris is actually recessed all the way down here. So this is called iridocorneal angle recession. The other interesting thing is that the iris itself is slightly thick and kind of off-white. The color doesn't really make that much of a difference, but it also has these multiple nodules that you can see poking up above the surface. So it's got kind of an irregular surface. And then the rest of the globe is actually relatively normal. So we have a nice normal lens. There is a little bit of hemorrhage. They did note hyphema. Some of that may have been settling here as well. There's a little bit of hyphema blood in the posterior chamber as well. The back of the eye looks pretty normal, despite they did say glaucoma. The optic nerve is a little bit hard to see in this image, but cats' optic nerves always look slightly recessed, because even when there's not glaucoma, because their axons of the RGCs don't myelinate until after the lamina cribrosa. So they always look a little bit recessed. But anyway, unlike a dog. Okay, so let's go to the slide now. Okay. Focus, maybe. Wait for it. All right. The center is more or less in focus. Okay, so cornea is to the left here. We've got a little bit of corneal distortion. This is just an artifact. And then this is another artifact where that iris leaflet looks like it's floating in the air. But what you can see from this magnification, even though it is floating in air artifactually, is that it's a little bit more purple than it should be. And so is the ciliary body. So let's go look over at the other side. This nicely displays the iridocorneal angle recession. So the base of the iris should be approximately right here, and you can see how far recessed it is. And then this iris leaflet is a little bit more purple than it should be as well. And we have this beautiful extra slice of the eye right here. And in this area, the iris leaflet is a little bit too purple, and it's also very distorted. So it's expanded by a population of cells. So let's figure out what's going on. Okay. And actually, let's start with that slice. So lower mag, or slightly higher mag than we just were. It's not quite apparent what is going on, but there's some sort of cellular infiltrate in the iris stroma. And when we get slightly higher, we have sheets of cells. And when we get even higher, you start to pick up a little bit of pleomorphism. So some of the nuclei are quite big. And there is variation in nuclear size, and that kind of implies that there's a variation in cell size as well. So we have a population of what kind of looks like round cells, but it's really kind of difficult to see their borders. So we have a population of cells, And in this image, we have at least 3, maybe 4, maybe 5 mitotic figures. So we've got a pretty mitotically active population. Let's go out and look. Here we go. There we go. There's some fun ones. Okay, so here's the much more marked variation in cell and nuclear size. So we also have a cell that has 2 nuclei here. And then, whoops, this guy right here has what we call a nuclear pseudo-inclusion. So it just is, presumably it's invagination of the cytoplasm sort of into the nucleus from another plane of section. So the nucleus is probably still intact, just looks like there's cytoplasm in the middle of the nucleus. And once again, here's at least one more mitotic figure. Oh, here's another one right here, maybe one right there. So really mitotically active population. Let's see here. I was not impressed by pigment in many of the cells that I thought were neoplastic. However, like for example, right here, maybe this cell has a big nucleus with kind of more open chromatin pattern and probably some cytoplasmic melanin. So this is actually an iris melanoma in a cat. It is poorly pigmented in this case. And I just thought it was adorable because I love it when they have such amazing variation in cell and nuclear size. This one also has displays one of the features that sometimes FITMs do, the feline diffuse iris melanoma. We abbreviate that FITM. That they tend to carpet some of the surfaces of the anterior uvea. So here we can see it carpeting the back of the iris and the ciliary body plica here, and also the pars plana there. So, and here that the purpleness that we were seeing at low mag is what is also neoplastic cells that we were seeing. And actually in the gross photo, you can see these like sort of strands of iridoid tissue that span from the iris up to around about where the base of the iris should be. So I think these are remaining distorted iridoid tissue or something like that. That are, yeah, maybe, yeah, stretch pectinate ligaments, yeah. So anyway, there are also neoplastic cells on the back of the cornea. And the corneal stroma is also slightly vascularized. I think there's an ulcer here as well. Sorry, it's very distorted right here. But there's an ulcer and there are some neutrophils in the stroma responding to that ulcer. At least a few squiggly nuclei in there. And so here are some of the blood vessels. So we've got some corneal stromal vascularization and an ulcer. Let's see here. So the iridocorneal angle recession is an interesting lesion that we see in a couple of different instances. The significance of it, in my opinion, is that it really distorts and probably affects the aqueous humor drainage out of the eye. So the aqueous humor collecting channels, or the angular aqueous plexus, are right here. And normally the base of the iris is kind of right here, and the trabecular meshwork is in this area. But it often ends up being quite collapsed, at least histologically, when we think that there's iridocorneal angle recession. So one of the times we'll see this is with cyclodialysis, which is traumatic tearing away of the iris and ciliary body from the sclera. Another of the times we see it is with tumors, actually. And I'm not quite sure we don't know why it happens. And then sometimes we'll also see it simply with ophthalmos. So when the globe enlarges, you'll get this recession of the iridocorneal angle. And then it can be kind of a chicken or an egg situation, because ophthalmos will cause thinning and stretching of the limbal sclera. The limbal sclera is right here adjacent to the cornea. And so we're never sure if it came first and caused glaucoma due to decreased aqueous humor outflow versus glaucoma developing ophthalmos and then iridocorneal angle recession. So the lens was pretty boring in this case, and then we can go back and look at the optic nerve. So from a low mag view, this is an atrophied feline optic nerve head. So normally the optic nerve should come up and be about right here, and you can see that it is recessed in this image or in this area, in this globe. And then when we look for the retinal ganglion cells, which are the cells that are lost in glaucoma, they should be right here, and they are not. So we are missing retinal ganglion cells from this globe, and that is due to increased IOP and glaucomatous degeneration. So those are the main features of this case. One thing I didn't dwell on is the actual distribution of the tumor. So it affects the iris stroma and the ciliary body stroma, but it does not extend into the sclera or into the choroid. So that means that we would diagnose this as a garden variety FITM or just a regular FITM. Oops, what am I doing? Here we go. So here are the diagnoses for this tumor, for this globe. Feline diffuse iris melanoma. I said it was poorly pigmented. I probably should have included that, but clean margins, and then iridocorneal angle recession and chronic secondary glaucoma. What was I going to say? Oh, so they had diagnosed anterior uveitis, and I imagine they did that because of that weird expansion of the iris stroma by the tumor, which clinically can look very similar to lymphoplasmacytic infiltration of the iris stroma in the case of actual inflammatory, like actual uveitis. So that's probably why they described it as chronic anterior uveitis. Interestingly, they say the other eye also has anterior uveitis. We have very, very, very few cases of bilateral FITMs in cats. They do happen rarely. So I'm not sure. They did say this cat had toxoplasmosis, so maybe that was causing the uveitis in the other eye.
It's more likely that the other one has actual uveitis or any other change that causes aqueous flare or the clinical appearance of an ocular inflammation rather than bilateral feline diffuse melanoma.
Yeah. Cool. All right. I will go ahead to my next case then. So I only have a clinical photo from this next case. This is a 10-year-old Siberian Husky. The history we got was presented for glaucoma in the right eye, which is this one, diagnosed 2 weeks prior. Ophthalmic exam revealed iridal hyperemia and a non-pigmented oblong mass effect over the iris base, extending roughly from the 9 o'clock to the 12 o'clock position of the iris base in a clockwise direction. So I think that would be from here to here, if I'm doing that clock math correctly.
Yeah, I always have to.
They say the dog had a blue eye. It's a little bit gray brownish in this one. And then the iridocorneal angle of the contralateral eye revealed sheets of pectinate tissue with numerous large flow holes and appeared dysgenic but not closed. The dog also has a liver mass identified on pre-anesthetic staging, and they did an FNA, and the results were pending when they submitted this to us. Thoracic radiographs were within normal limits and no other general medical issues. So here's our clinical photo. So they describe an oblong mass effect at the base of the iris, which is close to where it meets the sclera, from 9 o'clock to 12 o'clock. So I think it's this right here.
Yeah, it's not that obvious as a mass, but
no, not obvious in this picture. One of the other interesting things to point out is this eversion of the iris epithelium onto the surface of the iris, the anterior surface of the iris, right around the pupil in this area. So clinically, they didn't actually mention that, but we would call that ectropion uvea, which is when the iris epithelium is pulled around to the front. Okay, so I didn't take a gross photo of this one. So I can't share that with you, but we got to see the clinical picture. Just kidding. Sorry. Thought I gave it away. Okay. All right. Same deal as last time. Coordinates to the left. Oh, let's put some stuff in the middle and get it into focus. Okay. So kind of similar to our cat eye, the iris and the ciliary body, which are now out of focus, are expanded by a slightly purplish population of cells. So it's really apparent on this side. And over here, it is not quite as apparent, but there are a few little foci in the ciliary body stroma here. And then we have an extra slice here, and it's not as obvious in that one. So the lens looks pretty good. The optic nerve in this image, in this plane of section, I should say, looks pretty normal actually, but the retina is a little bit atrophied, so I think we'll look higher mag. Anyway, so let's jump right in and figure out why this iris is chubby in this case. So go right to the fun stuff. So from a low mag view, we can start to see there is a population of spindle-shaped cells in the iris stroma. And when I go out a little bit further, closer to the pupillary margin, we can actually see some relatively normal iris stroma here. And then you can see how densely cellular this infiltrate is in other areas. And when we go higher mag, unlike the last tumor that we saw in the cat, these cells are much more spindle-shaped. And kind of form these interesting streams and bundles. So you can see like, here's a stream, and this area here is probably one cut in the opposite direction. So this is a cross-section of that stream of cells. And when we go higher mag, the cells are spindle-shaped. Their cell borders are not very obvious, but they have this sort of finely fibrillar eosinophilic cytoplasm and elongated nuclei with sometimes multiple nucleoli. And you can see in this image alone, there are 1, 2, 3, 4, 5, 6, 7, 8, 9, at least 9 mitotic figures. So this is an extremely mitotically, hugely active tumor. I counted 110 or something mitotic figures in 10 high-powered fields, which is high. And then let's just go back out a little bit and appreciate the pattern that we're seeing here. So it's just a really interesting, very pretty pattern of this sort of bundles and streams of neoplastic cells kind of interlacing. And then let's go look at the other side. So one thing I should point out at low mag, and we'll go higher and look at it there, there's really no melanocytes in this iris stroma. And when we go a little bit higher, there are a couple. So there are a few right here. But this lack of melanocytes is consistent with a blue eye. So we looked at the clinical photo. We kind of said, oh, that looks kind of like grayish iris. But anyway, this is a blue eye. It is a Siberian Husky, so they commonly have blue eyes. And so what we're seeing here is a very similar population of atypical spindle cells on the iris surface and also in the ciliary body stroma on this side. And you can kind of see how they infiltrate the ciliary body stroma and go kind of out even into the plica, the stroma of the plica. So here's that. Let's see here. I was looking at the morphology of the iridocorneal. Okay, that one's no use at all. So they said that the other eye was goniodyspgenic. Well, actually, before we go there, so this is a tumor in a blue eye. It is in the iris. We didn't see any pigment in it. It is spindle cells that are forming these really pretty interlacing bundles and streams. And this is consistent with the schwannoma of the blue-eyed dog. And this is a tumor that we see mostly in blue irises. On a rare occasion, we'll see a tumor in a brown iris that looks very similar. It is actually really difficult to differentiate a schwannoma from melanoma because there's actually a lot of overlap. From a non-pigmented and amelanotic melanoma, because there's a lot of overlap in the immunohistochemical markers that they will express. Sometimes we will offer a glial fibrillary acidic protein to confirm a schwannoma. I didn't in this case because I was pretty confident that that's what it was. So most of the cases we see these in are huskies. because most of the blue eyes that we receive are from huskies. However, they can occur in any breed of dog with blue eyes. And we don't know why that is. We don't know why there's a propensity for blue-eyed dogs to develop this.
One thing that we don't know if that is an explanation, but there's a difference between blue eyes and heavily pigmented brown eyes in the numbers of and the presence of Schwann-like cells throughout the anterior surface of the iris. So it could be a matter of chance, like blue eyes have more of those cells than brown eyes, so they have a higher likelihood of one of them going crazy and becoming neoplastic.
Cool.
So someone is asking you to repeat the differentials for the Schwannoma.
Okay, the main differential, I feel like the top three are Schwannoma for this kind of appearance in a blue-eyed dog. But an amelanotic melanoma is something that should be considered. However, it is difficult. I mean, you could try a marker like PNL2, which should mark melanomas, but not Schwannomas to my knowledge. But then it's sort of like ruling out a melanoma as opposed to definitively saying that it is a Schwannoma. So GFAP is, so when I've done GFAPs on these tumors in the past, I feel like a small percentage of the cells are positive and they are not very strongly positive. And therefore my bias is to have stopped offering it because I find it somewhat dissatisfying, and I could have just said it's a Schwannoma without spending extra money.
Yeah,
so I don't know.
In the end, the presentation is very classic. You got a blue-eyed dog with the tumor that's most often than not forming a well-delineated mass, has this infiltrative appearance, fusiform cell. It looks like a schwannoma or a peripheral nerve sheath tumor that you would see anywhere else in the body. So all of that, it's pretty characteristic. If you had a few that look a little bit more malignant with more cellular pleomorphism, you might want to do to try to differentiate from melanoma, but still it will be my first choice, and it'll be extra careful.
Yeah.
You know, it will be honestly unnecessary almost, but
yeah. So another differential that you could potentially sort of consider is something like a fibrosarcoma. However, I think that is like ridiculously rare.
you don't see that very
If
often.
anything, those often would be metastatic to the eye, if anything, and then they wouldn't be necessarily in the uveal stroma. A leiomyosarcoma you could consider as well. You could try to rule that out with a smooth muscle actin. I know we have a small handful of those in the collection, so they're very rare. So those would be the main differentials that I would include for this tumor in a blue-eyed dog. So I pointed out the ectropion uvea in the clinical photo, and we didn't really capture it very well in the sections that we have here. So you can kind of see that iris epithelium being pulled around front, but it was much more dramatic in the photo. So it probably has to do with where we sampled this eye. So the prognosis for these is generally very good. Clean removal, complete surgical removal is curative. However, this one was like crazy mitotically active and like kind of pleomorphic compared to a lot of them. So I cautioned them that this one was a little bit scarier than I'm used to seeing. And I forgot to query them about the FNA results. Maybe I should try to get back to them and see if the liver mass came back as anything.
Yeah, so Aaron Scott is asking, so schwannomas have a risk of metastasis, while amyloid melanomas would probably not in the eye. Is that correct? I think so we had a few cases of schwannomas that uveal schwannomas that metastasized. I don't think we have enough data to come up with specific numbers in terms of metastatic risk, but they can metastasize. And melanomas can metastasize too. They're just not as common. So I would put them at the same level of metastatic potential, to be honest, which is not high, but possible.
Yeah, which is very low. Yeah. Cool.
Part of the reason why I don't bother if I see either because the prognosis is probably similar.
Oh, that's a good point. Yeah. I mean, I guess with this one, like, especially over here where it was carpeting, you might be thinking like, oh gosh, could this be metastatic? And then it might be more important to try to differentiate them. But this one had that beautiful area of uveal stromal expansion, which is more consistent with a primary tumor that developed in the eye first. So
Yeah, the bottom line is the more you think about those things, the more you work yourself up. But if you have someone describe it to you, you got a blue eye husky with a tumor that looks just like that, you'll be like, yeah, that's Schwannoma. But trust your gut. That's the main point of this.
Yeah.
With the trophy on UVA,
Mhm.
is there a pimple that we just can't see, or it just from the mass effect?
it's the neoplastic cells themselves that end up causing the ectropion UVA. It's really kind of a unique thing for Schwannoma specifically. And sometimes we'll get a clinical history of like a change in eye color from blue to brown, which is weird. Yeah, so that's interesting. So that is a really unique feature. I was gonna say one more thing. In the past, I had somebody consult with me from outside of UW about a blue-eyed globe that had something going on, and he had diagnosed it. It was a lot less pleomorphic than and less densely cellular than this tumor was. But he had actually diagnosed like uveal fibrosis. Because oftentimes the spindle cells are so bland that sometimes it is kind of hard to convince yourself that it is a tumor. I counseled him that we were taught by Dr. DeBielzig that uveal stroma does not typically undergo fibrosis. It's incredibly rare. So if you are looking at a blue eye with something going on in the iris and you're like, I want to call this fibrosis, check yourself, ask yourself 14 times if it could be a Schwannoma. Yeah. All right.
Awesome. All right. So, hi, it's Jamie. Not a Schwannoma. Nope. So I'm Jamie. I'm another one of the staff pathologists here at Coplow, and I've got the next two cases for us. This one starting off is a 7-year-old female sprayed mixed breed dog. I'm going to try to give you the history with leaving out some few key details and hopefully not butcher the history too much. So about 3 weeks prior to enucleation, the dog presented because there was a retinal detachment in the right eye with mild secondary glaucoma. The IOP at that time was 29. It responded well to medication. And then with further treatment, 2 weeks later, the eye developed hyphema again. And at that point, refractory glaucoma with the IOPs in the 50s and 60s. And so they enucleated the globe. And so this is what we saw grossly. This is our hemisection view. We've got our cornea at the top. In our anterior chamber here, we've got this cloudy gel. It's very thick here. Here's our iris stroma here. Here is our lens. And then the posterior chamber and the vitreous are just expanded and filled with this red hemorrhagic to tan. Hopefully you can see a little bit over here that it's a very cloudy and very solid sort of gel material in the chambers here. And so that is what we're going to take a look at. This globe is very big, so it ended up on a large slide. So we'll see if we can. Go. All right, so very large slide, so bear with me here. All right, so sort of cornea at the top here. Again, we can see that cloudy gel that's in the anterior chamber is this very hypereosinophilic homogeneous material. Here is our iris stroma coming across. We did not sample the pupil, so there's no space here. And the rest of the posterior chamber and vitreous, again, very hypereosinophilic homogeneous material admixed with some hemorrhage. This little purple squiggly line here is our retina. So the retina is detached. And we only get caught a little sample of our lens in place. So, and then here is our optic nerve. So taking a closer look at what we got here. All right, come up towards the front. Here we go. So cornea here on the left. So we have our corneal epithelium, and then we lose our epithelium. And so we've got a nice corneal ulcer here. We can see neutrophils and blood vessels coming in. We see kind of this delineation here of neutrophils trying to get to the center of this ulcer. It's maybe a little bit less cellular here than usual. So there might be a little bit of corneal necrosis going on. So maybe an early sequestrum forming. But we can see blood vessels here in the periphery of the cornea also have this hypereosinophilic material. Got a little bit of artifact here of our angles a little bit chopped up here, but we can see this nice thick fibrovascular membrane on the front of our iris. So we have a pre-iridal fibrovascular membrane. Come over to the other side. You can see that it kind of crosses here, forms a little peripheral anterior synechia as well. Again, most of our blood vessels here also have hypereosinophilic material, which is again in the anterior chamber and in the posterior chamber in the vitreous. So again, here's a little squiggly portion of our lens, which was a little bit hard to assess since we only got a small portion of it in the section. Here is our retina. It is detached, floating in this hypereosinophilic material. It is torn. We've got some nice rounded edges to the ends of our retina here that sort of helps differentiate it from an artifactual tear, which usually looks a bit more boxy. And then we sort of lose our definition of our retina and the layers here. So there's retinal necrosis. That's segmental. And if we follow it along, and we get to see a little bit of more of our layers here. There's still a couple ganglion cells here, there, but also the vessels here in the retina have very similar material as to what's in the chambers and in the spaces and in the subretinal space. Then we have a bunch of hemorrhage in here, and there is there are a lot of spindle cells in here. They're very bland. They're starting to maybe form some blood-filled vascular channels. There's some vasculars here. So we have a fibrinoproliferative lesion. So just some organizing of this hemorrhage going on in the globe. You see that sometimes with retinal detachment, necrosis, and ischemic events. And then again, back here in our choroid, in our peripapular tissue, again, all of this hypereosinophilic material in the vessels with our red blood cells here. And so all this hypereosinophilic stuff is very high protein rich. And so this is consistent with a hyperviscosity syndrome, which is actually what they diagnosed clinically when this globe initially presented. And so when we have these lesions, we start to think about things that can cause really high protein in the blood. And so all that proteinaceous material is leaving the blood and getting into the globe. And so this is often associated with a monoclonal gammopathy. And this dog was actually diagnosed with multiple myeloma, which is what it was underwent treatment for clinically. And so they gave it prednisone and treated with melphalan. And then afterwards, that's when it got thrombocytopenic and bled into the eye again. And so that is what caused the second episode of blood in the eye for this case. So it was pretty nice to have that history to come along with the globe in a very just a nice classic presentation for this syndrome.
Yeah, just to add a few things. So we often see with a hyperglobulinemia or hyperproteinemia, but there are some instances of polycythemia that can cause hyperviscosity syndrome too. So it may not be just protein, but increased cellularity. And in the Gammopathy can come with not only neoplastic processes, but also infectious processes. Some chronic infections like ehrlichiosis can lead to, I want to call it gammopathy that would potentially lead to hyperviscosity syndrome. By far, in our cases, the most often cited cause is neoplasia and a multiple myeloma, but just got to keep that in mind. Wouldn't rule out hyperviscosity syndrome just based on the absence of a neoplasm.
Yeah. Yeah, so we don't always get a history of having multiple myeloma or other neoplasms or other blood work abnormalities. So if we see that sort of lesion histologically, we do often query and ask them, you know, were there any blood work abnormalities or possibility that this dog could have multiple myeloma.
And just for the pathologists out there, if you're worried about, well, how can I differentiate that hypereosinophilic stuff from just basic hemorrhage and you know, a proteinaceous exudation? If you do a PAS, normally if you have just hemorrhage from, let's say, trauma or hypertension or something like that, just chronic hemorrhage in the eye, you do a PAS. The PAS will actually the hemorrhage itself will get a little less obvious because it tones down all the red from the hemotoxin in the red blood cells. With these guys, with hyperviscosity syndrome, if you do a PAS, that background proteinaceous exudate tends to be much more PAS reactive, let's put it that way. I wouldn't call it PAS positive, like the basal membrane, but it gets more magenta, like, and you can see that same reaction happening inside the vessels, which suggests that it is the same protein-rich material. So that might be one thing that can help. Just putting that out there.
Cool. Right. All right. I know we just saw this case, but so next up is another dog, 7-year-old female spayed Labrador Retriever. This dog presented in March of this year with vitreal hemorrhage / plaque, retinal hemorrhage, and focal retinal detachments. Was diagnosed with systemic hypertension at that time. It's now currently being controlled. Their workup for underlying causes of the hypertension were unrewarding, and the other eye is relatively normal. So they wanted to just rule out any other possible etiologies. They did notice a period of hypervascular membrane in the right eye. And so just wanted to see if there was anything else going on to help with their patient. So grossly, the globe was boophthalmic. Everything was pretty fine until you got back here into the anterior vitreous here, and I adored this description of a cute blob of tan stuff in the anterior vitreous. And so that's what we have here. I think sometimes it might be referred to as like popcorn looking lesion, I think maybe clinically.
We try to be more, you know, sort of than that sometimes when you write descriptions, but it's blobby, it's tan, and it's cute. So sometimes, you know, that works too.
It works. It gives us a joy as we're reading the gross notes from.
We don't go out very often, so we have to amuse ourselves in other ways.
Yeah. Okay, so let's take a look and see what that is. Let's see. I will say that that stuff in the anterior vitreous was not captured in our original section, so I had to go on a hunt for it. So I've got some deeper sections, and if I can, so we found it. Very cute, is adorable as described grossly. So yeah, not a whole lot going on the anterior portion of the globe, at least from subgross, although we do have some stuff over the angles here that we'll take a look at. And we have our little material here, retina. And then again, a little bit deeper, so our optic nerve is getting a little distorted here, but it's a bit cupped here in the space, and we'll take a look at that as well. Yeah. All right. So let's see. So they had noticed a period or fibrobascular membrane clinically, and it does look like we do have some cells and blood vessels lining our anterior surface of our iris. The other thing that was interesting about the angles, before I get back to our vitreal stuff, and this was the best example of it, is that we have an iris-like tissue that crosses our angle here and connects directly to our arborizing end of our Descemet's membrane. And we lose our trabecular meshwork and our ciliary cleft here. So this is consistent with goniodysgenesis. So that is also occurring in our patient. Labrador Retriever. All right. And then our material here in our anterior vitreous, just kind of a collection of spindle to polygonal cells. They're pretty bland looking, indistinct cell borders, no blood vessels associated with these guys. Sometimes they can be necrotic looking. Not so much here. We didn't get maybe all of the sample, but we caught some of it here. I think with in other cases, we've run immunohistochemistry, and these are GFAP positive. So consistent with glial cells. Not really sure where they're coming from, to kind of an unknown origin and why they're here and why they proliferate here. But oftentimes they are associated with vascular proliferation at the optic nerve head. And it might be a little difficult to appreciate. You know, I'm going to show you the other level because it showed up because I couldn't catch all the lesions all perfectly on one slide. So let me come back here.
There.
So here we go. So we have a very nice cup to our optic nerve, and then proliferating on top of our optic nerve head here is a little vascular tuft. We've got some nice little blood vessels here, which often go along with those cells in the anterior vitreous. And so this is consistent with Canine ocular gliovascular syndrome, or COGS. So COGS in dogs. So again, the proliferation of the glial cells in the anterior vitreous, again, often associated with this vascular proliferation here at the head of the optic nerve head. We don't always catch it in our sections, but it's very nice to see it together. And usually that leads to intraocular hemorrhage, which we do have a little bit here in our vitreous. Yes, so I think that was it for this globe. So we have COGS and we have goniodysgenesis. And actually, COGS was on the differential list for from the clinician as a possible other thing going on. I guess I didn't show them very closely, but the blood vessels in the patient were in our section were normal. So we didn't catch any signs of systemic hypertension, which they were currently managing. We don't always get vascular changes, even when there are cases of, systemic hypertension reported. So it doesn't rule it out. But if we do see it, it's something that we often caution the clinicians to maybe check for systemic hypertension.
So I was just hearing Dr. Bilzig in my mind saying most of our COGS cases are Labrador Retrievers.
Yes.
And as I was thinking this, he sent a message that says half of our COGS cases are in labs.
Exactly. Yes.
So the mind Melvin
It's
is working out there and then carrying around her, sending him a heart on his message, which makes me think she was thinking the same thing, which is funny.
Yes, yes. So COGS is usually a unilateral disease, and it's not associated with any sort of systemic disease. And yes, about half of the cases in our collection are Labrador Retrievers, but the other half come from like a wide variety of different breeds. Um, it can be seen in anything. It was tricky here, so we have our COGS diagnosis. There's also gonadisgenesis. We also have membrane formation. So it was a little bit difficult to maybe parse out which one of these lesions was maybe more responsible for the development of glaucoma. But
Or all of them.
or all of them together. As I said, COGS is usually unilateral. Gonadisgenesis is usually bilateral. So they should maybe look at doing gonioscopy on the other eye, confirm that it's got gonadisgenesis as well. And it might maybe have an increased risk of developing glaucoma later, but it's hard to say if this dog didn't have COGS, if it would have developed glaucoma, because not every dog that has gonadisgenesis goes on to develop glaucoma. So something for them to just keep an eye out for in the other eye.
Yeah, so these cause cases are not always identified clinically like this one. Which makes me very happy because, people are paying attention. And more often than not, I think when you see that anterior vitreal proliferation of cells or opacity you see clinically, that should come up as a differential. In this case, it did. But most often than not, they're not diagnosed with COGS. And the reason they get nucleated is because of secondary glaucoma. We think the main lesion are those glial cells proliferating in the anterior vitreous. We don't know if they're remnants of embryonic tissue that should have disappeared, or they're really newly formed, newly formed cells in there, glial cells of some type of origin. But I think what they really cause is this, that if you look at those cells, they are avascular. And I think they become ischemic very often when they get big. You see areas of necrosis. So I think the necrosis in the ischemia releases VEGF, and then it might lead to secondary vascular changes. We don't know if the optic nerve vessels are a secondary change or part of that embryonal tissue that never, atrophied. But what they usually develop is a neovascular glaucoma. They often have very, very impressive peripherovascular membranes and develop secondary glaucoma. This dog was unlucky enough to have COGS and gonadisgenesis, so his faith in terms of glaucoma was settled right there. But they usually develop secondary glaucoma.
Okay. So my name is Megan, and I'll do the last cases. We may only have time for one. I kind of feel like I should just go to the last one, but I don't know. We'll see what we get.
This one.
Do the last one? Okay. All right.
Well, try
wait.
that one because
Okay, let's see if I can get through this one quickly, and then we'll do both.
visitor here that might enjoy them.
Oh, interesting. Okay. So we only have a clinical photo for this one. Thank you very much to the clinical team for taking this, but we are trying to maintain anonymity, so anyway, this is what we're doing right now. But anyway, so this is a 9-year-old spayed female domestic short-haired cat. They describe an irregular third eyelid with lobular mass that is friable, which you can see in this image of the right eye. We have this friable, kind of lobulated looking mass, sort of red or hyperemic on the third eyelid, kind of close to the leading edge. So
The other one's really good.
yeah, the other one is really, really good. All right. Hopefully we're not teasing that and then not able to get to it. All right, super speedy. So here, focally extensively replacing the epithelium of the third eyelid conjunctiva and diving into the substantia propria, we have this highly cellular population. So just to orient us, here is the leading edge of the third eyelid. This thing down the middle is the cartilage of the third eyelid in cross section. And then down here, especially at the base and on this side, there's third eyelid gland. So diving into the neoplasm itself.
because it is a neoplasm. It's epithelial. We've got formation of these anastomosing cords and lobules. We've got replacement of the surface epithelium with this disorganized epithelial population. It dives deep enough to basically directly abut the third eyelid cartilage. And here it is, forming lobules, anastomosing cords, tuberculae, so on and so forth. If we look around, sometimes in the midst of the neoplastic populations, it does kind of look like they're forming tubular shapes. Maybe pseudoglands or maybe just straight up tubules. Sometimes this could be like necrosis in the center of globules, though, and it sort of looks pseudoglandular like that. But that's kind of interest in this case, as well as the anatomic location. So more of that with maybe some protein in the middle. And so, yeah, long story short, this is a carcinoma. In a third eyelid of a cat, a carcinoma, especially the one that kind of forms papilliferous projections from the surface, and maybe tubular or kind of glandular type structures in the substantia propria. The top differential for this would be feline conjunctival surface adenocarcinoma, formerly referred to as mucoepidermoid carcinoma because there's kind of a similar entity in humans maybe, but better to call it feline conjunctival surface adenocarcinoma. A reasonable differential for this case is like a poorly differentiated squamous cell carcinoma. So you could include that on your list. Either way, this is a malignant epithelial neoplasm. It is a carcinoma. It's locally aggressive and invasive. And it has metastatic potential. Check the lymph nodes, sort of a situation.
Oh, we had a third eyelid gland carcinoma.
Third eyelid gland carcinoma is another thought. It does kind of blend into the gland here. So yeah, good point.
Especially when you get superficial biopsies or small biopsies that you don't know where it's coming from.
Mm-hmm.
You can't look glandular in some areas.
Yeah, if I recall correctly. There's sort of some weird changes in the epithelium towards the margin, but the actual neoplastic cells themselves did look completely excised in our sections. A lot of times these lesions will be on a continuum, essentially from dysplasia through in situ carcinoma to straight up carcinoma. So that's the diagnosis for this case. Feline conjunctival surface adenocarcinoma tends to have a predilection for the third eyelid in cats. There's a thought that it may be arising from ductular epithelium, but it's somewhat unclear at this stage.
Of the gland of the third eyelid.
Of the gland of the third eyelid. Ductular epithelium of the gland of the third eyelid is the thought. Okay, all right, last one. This one is a classic. So this is a 3-year-old spayed female German Shepherd. Wink, wink. So this patient had glaucoma of the left eye, iris of Bombay of the left eye, non-visual with absent light perception, hyphema, and anterior uveitis. They also noted discospondylitis or discospondylosis. That's important. Discospondylosis is what they say, which is often kind of an incidental finding in aging patients, but this is a young patient. But anyway, potentially unrelated, and we're not going to get hung up on the details. So we're going to go back to the eye. So we have a cloudy cornea up here. We do have iris leaflet here. It's a little bit hard to tell, but the iris leaflets are kind of adhered to the center of the lens anteriorly at kind of the anterior pole. And then the iris leaflets are kind of thin and anteriorly bowed. If you look at this from the front, it would probably look like a big donut. And basically this is iris Bombay. So we have a 360-degree posterior synechia. The aqueous can't get through the pupil anymore. You get this kind of forward billowing of the iris. That's kind of iris Bombay for you. So check iris Bombay. The main thing in this case, though, is all of this exudate inside the intraocular chambers. And in particular, note that this exudate is centered on the vitreal space. We have all this white tissue around the edges and then kind of this empty space in the middle. The retina is back here. It's definitely at least partially detached, probably completely detached, and looking a little thick. There's also hemorrhage in here too, lots of red. All right. Let's see if we can do a subgross first. All right. Here's a much more quiet anterior segment, and then the posterior segment is chaos. In this subgross, you can really see the iris Bombay even better. Look at that lovely anterior billowing and thinning of that iris leaflet. But that's not our main event. The main event is all of this exudate inside the eye, mostly on the posterior segment, and often quite centered on the vitreous. So let's take a look Here's our cornea to the right-hand side to orient you. We have all of these inflammatory cells, especially lining the vitreous. There's lots of high protein fluid, subretinal and vitreal in particular. We have inflammatory cells lining the epichoroidal surface and lining the surface of the retina, epiretinal surface. And if we zoom in on some of these cells here, a lot of these here are variably degenerate neutrophils. So we've got suppurative exudate. If we zoom in on our cells that are carpeting surfaces, we have a pyogranulomatous inflammation, which is composed of epithelioid macrophages, these big plump epithelial-like macrophages, and then in the center, variably degenerate neutrophils. These are basically coalescing pyogranulomas along the epichoroidal surface, and also pyogranulomatous inflammation along the epiretinal surface as part of a membrane that's there that's fibrovascular. So we have a lot of pyogranulomatous suppurative reactions centered on the vitreous especially. When we see pyogranulomatous inflammation, we think fungi. And one of the places that I'd strongly suggest that you go if you're evaluating eyes is the basement membranes, including Descemet's membrane and the lens capsule. Don't forget to evaluate those. Those can be great places. And in fact, there are some really fun things if you look towards the lens. There's a better one over here. The lens capsule is multifocally ruptured. We can see that there are tunneling of neutrophils into the ends of this lens capsule and macrophages lining those exposed lens fibers. There's another big rupture site. And the lens capsule comes back. So then if you look closer at the lens capsule itself, particularly next to those areas where it's ruptured, we have friends. So we have somewhat poorly staining structures, which, yes, two basophilic staining. And these are fungal hyphae. You can see them sectioned in more longitudinal section and in more transverse section here. Part of the reason why it's good to look at base membranes like this, it's more sort of empty or homogeneous space, and the fungal hyphae tend to stand out. And then they do enjoy basement membranes, presumably a nice carbohydrate-rich environment like a giant pink fettuccine noodle. I don't know. I do enjoy fettuccine myself. So the other thing is, before we move on, because there's actually a lot more fun, another thing in cases like this. So we have all of these inflammatory cells at the edges, which your thought may be to kind of zoom in on those. But sometimes, again, looking at kind of the emptier areas might be better. And or if you see how the neutrophils kind of like track in these weird like tracts, like linear tracks almost, that's also very suspicious. Yeah. And indeed, if we look closer at all of this, they're everywhere. Friends. Let me see if I can find like, I know I'm gonna find a really good one though.
Go ahead.
Okay.
Oh, just looking for some space. Oh, there you are.
There we go.
Okay.
Yes. Thank you. I'm well trained. Clicker trained. So we have fungal hyphae. They do have parallel walls. They have regular septations. They have kind of acute to maybe right angle branching. And most fungal hyphae that look like this are going to be aspergillus, but you absolutely cannot speciate fungal hyphae in section. There's a lot of crossover in terms of histomorphology of different fungus. So if you really wanted to speciate, you'd have to get fresh tissue and do a fungal culture, or on this tissue, we could do PCR. And yeah, so we have a fungal or mycotic endophthalmitis. More to the point, is kind of centered on the vitreous. So we could call it a mycotic vitritis. And ultimately, this sort of fungal hyphal-induced endophthalmitis is something for which German Shepherds are overrepresented, and then beyond that, even spayed female German Shepherds are particularly overrepresented for some reason. You'd imagine younger female spayed. Yeah, so basically, this is part of the reason why this case is classic. 3-year-old spayed female German Shepherd with a mycotic vitritis. You kind of wonder if it's because they tend to have sort of like genetic kind of immune-mediated shenanigans in German Shepherds, but ultimately, all I can really tell you is that it's overrepresented, spayed female German Shepherds in particular.
And that's because they have a systemic mycosis.
Yes, okay, yes, good point. Before we forget, this is almost certainly an ocular manifestation of systemic disease. So finding these findings in the eye histologically means that you want to check the rest of the patient for fungal disease elsewhere. Respiratory tract in particular is a good place to check, and just systemic mycosis in general.
Yeah, and as Kelsey Breaker pointed out, females in general, not just.
Yes, and sorry, not just spayed females, females in general.
Yeah, because most of the ones we get are.
Yeah, that's true. But yeah, that's probably just a population related thing. Okay, that's it. I made it just in time. Haha.
All right, thanks, everyone. See you guys in 2 weeks.
Well, obviously.
I always forget how to do this.
If you would read it.
Just
stop.
Just stop share.
Feels like we're gonna have. Yeah.
Okay, just one, just think.
Okay. Ah! Oh my gosh. What just happened?
Oh, we did stop at 10. Yeah. In an hour.
Okay.
Right.